Have you guys taken it?
Yes.
Yes.
Right. So the CAT exam, it's a mimic in a way of the NCLEX exam. It will bring out what you don't know and it will pound on it, which is a great thing, guys, because this is not a time to, this is a time to actually understand this is what I don't know, this is what I need to study for. And it works. Most of the students who take the CAT and they pass the CAT, they actually go on and take the NCLEX and pass the NCLEX. It's simple as that. When we started this, we were like, we hope it worked. They say it worked. Now at this point we know it works. It mimics it's the same algorithm. It mimics the NCLEX and it works wonders. So you should, if you have not taken this exam, I encourage you to do it as soon as possible. For those of you who have not taken it, because it's going to organize you in a way. It's going to show you where your weaknesses are and what you need to study on. And then from them on, you guys you know how it is. Study. And then I'll see you in the hospital in about, I don't know, a couple months, right? Are we ready, everybody here?
Yes.
All right, guys. So we're going to have to cram 56 chapters in 2 sections. So we can start answering questions afterwards. It's going to be 2.5 hours, 3 hours every Saturday. When we're done with this, with theory per se, we're going to start answering questions. Feel free to interact me. Feel free to challenge me, ask me, whatever you guys need, right? If you don't understand something, let me know. If my accent is too thick, let me know. If your question needs to be asked whatever you guys need, this is not a class, it's a review. My point here and my only objective is for you guys to understand this material. To really understand these materials. You're not studying this to pass a test of mine. We're not focusing on anything specific. We're here to review pharmacology today. And we're going to start from the first very basis and keep on going until you get the idea, okay? Many of these things are going to come back to your head like, oh, I remember that. Oh, God, yes, you remember that? We saw that. Who? I don't know what that was. I didn't do it. I promise you, I don't know what that was.
That was me. I'm sorry. That was
me. All right. It's all right. Let's start with this guy. So for the rest of you guys, my name is Hansel Diaz. I'm an RN. I have a master's degree. I'm a nurse practitioner, and I work at an interventional radiology team at North Shore Medical Center with nurses, physicians, and nurse practitioners. And I teach pharmacology at MIU. Many of you guys were my students, and we're going to be reviewing pharmacology today. Nursing process and drug therapy. You might get questions about the nursing process in the NCLEX. You might get nursing process. It's part of every question. It's the framework. If you're answering a question in the NCLEX and you don't have an assessment, most of the time the answer is going to be what? To assess. So you do need to know what assessment is. Do you guys remember what assessment is? What is it?
Hello?
What is assessment, guys?
Interview, interrogation, know
Collection of data.
things about the patient,
Gathering info.
obtaining data.
You're gathering info to the point that in a hospital, you won't be able to see a patient if you don't gather information, if you don't gather information. You can't start a procedure without an HMP. And you know what an HMP is? It's a list of things. Allergies that you have, medications that you take, medical conditions. Last time you went to a hospital, do you drink? Do you drink? Who is your primary doctor? Who is this other doctor? What kind of problems do you have? Why did you come here? Blah, 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 blah. So you assess. There's nothing that you can do without assessment. You'll fail. And questions could come where the stem of the question doesn't actually bring the assessment. And when you go down, what you actually are going to be answering is assessment. You remember that? Right? Then we have diagnosis, and you might get questions about diagnosis. We do diagnosis in a different way. We did not diagnose medically, right? How do we diagnose, guys? Are you guys here?
Yes.
So guys, how do you diagnose? If you were to identify a diagnosis, how do you diagnose? Based on what?
Medical history.
On data that you obtain.
Right, basically, but you don't, for instance, you don't say when we're nursing diagnosis, you don't say asthma. How would you say it?
Impaired gas exchange.
Right, or alteration to the respiratory system. Due to what? As evidenced by?
As evidenced by the symptoms that you are
and what are the symptoms of asthma?
observing. Dyspnea,
Shortness of breath.
wheezing, shortness of breath.
Right, perfect. That's the way you diagnose, right?
Symptoms.
It's the same thing, just in different words. You can't just put a medical name because you're still not certified to actually medically diagnose. You will be in the future if you guys want to. And then after you have your assessment, you have your diagnosis, what are you going to do?
Planning.
That's right.
Then intervention and then evaluation.
And then you evaluate. When you're going to plan, guys, you're going to set goals. And you're going to set them. Those are not long-term goals. Those are specific goals with time frame. Hey, listen, you have pain, and I want to alleviate your pain within the next 5, 10, 15 minutes, 20 minutes, 30 minutes, depending on the type of medication you use it. And I want to do it using this, this, and this. And I want to show you how to do it. And you need to help me. And then you perform the nursing actions that you already have in your plannings. And then you evaluate after that. How is your pain? Oh, it's better. Oh, that's great. We got it. Or no, it's not better. So we need to do something about it because the pain is not better. That's basically your nursing process, right? Do we use this in the hospital? Oh, hell yes. You use it all the time. You don't know. Sometimes you don't even know that you're using it. But you use it all the time. All the time, all the time. That's what you do all day long if you do your job the right way. Questions so far, guys, with this? Is there something specific that you want to know? Something that came out in your world that you want to talk about? Assessment. What is subjective and objective data?
Subjective, the patient the refers. vital signs.
Things that you cannot see.
Subjective. Find a definition of subjective for me. Tell me what it is. Tell me what you think it is.
What the patient tell you? What he feel, like pain, nausea, something like that.
Right, and if the patient is telling you this, if he's telling you, is there a way for you to prove it?
No,
Can you measure this?
no, that's objective.
That's right. So if a patient tells you, I have my COVID vaccine. I'm vaccinated. I'm on booster. Would that be subjective or objective?
Objective, because you have to check the code to see. It tell you that.
He tells you that, but can you prove it?
Until he present the code, the vaccination code to you.
That's right. Until he does, it's a subjective data. Now, if I take your blood pressure and it says 120/80, what is that?
Objective.
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 You're measuring that, right? Saturation 98, what is that?
Objective.
Objective.
That's an objective, right?
Yes.
Any
because
questions
You
with
mentioned-
that?
It's okay.
You guys are good?
Yes.
So you have you're doing your assessment and you're talking about patient history, right? You're starting with chronic conditions. You want to know what kind of drugs that the patient use. I mean, you have to know everything. You have to know OTC. You have to know herbs. You know how I feel about herbs, but you have to. You have to know if the patient smokes. You have to know if there are recreational drug, alternative medicines. You even have to know whether this patient has a specific religion. Why would you have to know if the patient is a religious person? Give me a basic example in the hospital about how religion can actually impact the treatment of a patient in a hospital.
For example, if that person is a Jehovah Witness, Jehovah doesn't accept blood. You have to know. And another things, if the person is a Jewish person, they are a diet special. You can give everything you want to that person.
That's two of the those are examples that we encounter every day in the hospital. Patient that is a Jehovah's Witness that says suddenly, listen, I don't accept blood.
Blood, no.
A Jewish person who needs kosher food,
diet.
kosher diet. He won't eat anything. The food has to be, prepared in a very specific way.
Yes.
Right?
Yes.
Racial, cultural. Why do we need to know about cultural attributes? Why?
Culture.
Professor, I have a question.
Sure.
If the
Right.
patient is a child and the parents is a Jehovah Witness, they have the right to decide if you can give blood to this child or not, if the child can receive the blood or not.
Yes. Yes, because the child is minor. The parents have to decide.
In an emergency situation that is life-threatening, the parents have the right to decide they don't donate, they don't accept blood for the child.
If it's not medically necessary and the parents are there, yes, they can decide. You could take them to court. It will be an uphill battle, to be honest. I personally have never seen this situation, thank God. But a child has a sort of a proxy, and yes, parents can make medical decisions for the child.
Professor Diaz, hi, it's Professor Azaretto. In regards to that question, if it's medically necessary, in an emergency case, 2 physicians can override the
Right.
situation.
As
with
long as the
pediatric
parents
children.
are not present, right, Liz?
Even if the parents are present, if it's medically necessary, 2 physicians, because it's a minor and it's a child, can sign it as medically necessary, save the child's life, and then go to court.
Right, it could happen. It's a gray area.
Yeah, it's a very gray area for that.
It's a
but
gray area. It's a gray
I found a
area.
question in ATI, and me and Carlos was thinking about this because we have the dog, like 3 months ago, and I have this question in my head
What
because
was
this is a child.
what was the answer in ATI?
I don't remember, but and I don't know if the question asked you about this, but you know, it wasn't a question for blood transfusion, and I think one of the options, the patient was a child, but you know, I always have this in my head. If is this a child, if the patient is a child, the parents are Jehovah's Witness, and they don't accept blood, but it's a life threatening for the child. You know, it's a big deal in the hospital. You know, because you are letting the child go to and die. But Professor Azareto, uh, tell us something that is important to know.
The thing about this, and this is a very good question, and I could find out legally exactly how it works. You could actually override, I mean, you could do a procedure medically necessary, a procedure or transfusion, anything can be signed by two doctors and the doctor who's ordering the procedure or who's doing the procedure. That will make it medically necessary. Usually we save medically necessary for procedures that are not, that you can't get consent from anybody. Let's say you have a person in the hospital and you have a proxy and you try to communicate with the proxy for a certain amount of time. You haven't been able to reach the proxy. 3 physicians, 2 nurses, they agree that, yeah, we're good. We're going to proceed with this. They fill up a consent or we fill up a consent. They'll sign. Everybody will sign the consent and we will proceed with the procedure per se as a medically necessary procedure. So we're overriding a right of the patient, which is the right to say what? No. Patient has the right to say no, even if that right, it's putting his or her life in jeopardy. They have the right to say no. That's one of the rights that you have. No is also an answer, by the way, guys. And sometimes it's frustrating because you are trying to do something for a patient and he's telling you, I don't want to. But they do have the right to say no.
Yeah, Professor Diaz, my personal experience as in the hospital, I've had patients with a hemoglobin of 5, 5.2, 5, and we know this patient needs blood, and the patient refuses because it's against their religious beliefs, and we have to respect it. We have to, and
Yes.
as long as the patient says no, and we're talking about an adult patient, okay?
Yeah.
As far as like medically necessary, it's seen more in the case of, let's say, coming into an ER, coming into an ICU, we cannot get a hold of the proxy, the patient's intubated, unconscious, cannot make decisions. 2 physicians will sign this medically necessary procedure. As far as the children, that's a whole different realm. It's completely different. The laws are going to protect the child, and the physicians do take over if it's life-threatening. Now, if it's not emergent, then the parents will make the choices. But one of the things that it's important for us to do when we're doing questions is that we look always at the age of the patient. Who are they talking about? What setting are you in? Are you in a tertiary hospital or are you in a community hospital? Are you in a clinic? Where are you? And who is your patient? What is the age of the patient? And according to age, there's special considerations we have to take in place. So with children, it's slightly different or significantly different.
You also have to take into consideration federal law and state law, because it's different when it comes to legal situation. It's different in every state. For instance, Good Samaritan law, which is mandatory in New York, it's a very gray area in Florida. That's one of your duties as nurses.
Can you explain that further?
about the Good Samaritan law, please?
What do
You
you
said
want
it's
to know?
different. You said it's different in Florida versus
Right. For
New
instance,
York.
in New York, you are basically forced to stop and help. Now, mind me, Good Samaritan is made mostly for regular people, not clinical people, right? People who don't know medicine per se, or nursing, or who have no training to take care of patients. So the law was made at the federal level to stop, help, and not being responsible for what happens to that patient afterwards, after 911 comes. It used to be that you had an accident and a regular person was there and he wouldn't stop because he was afraid that you could sue him afterwards, right? Are you following me?
Yes, I follow.
All right. So the law was made, and then you can go and help. The thing gets complicated when it comes to medical personnel. Why? Because you have training. It means you know protocols. It means you know what it needs to be done. And just because you're not getting paid or you're not working for a hospital doesn't mean that you don't have to follow standards of care. So when it comes to medical personnel, even if they're off duty, I'm talking about nurses, doctors, paramedics, firefighters, of course, anybody who takes care of patients, even if you're not on duty at that time, you have to follow protocols. So what happens? Let's say you have this patient who fell, hit his head and his back, and you stop. You're a nurse, or you're a physician, or you're a nurse practitioner, and you move the patient, and you didn't wait for the right people to be there. And after you did that, as a consequence of you moving the patient became paraplegic. So the Good Samaritan law will say that because you help the patient, they cannot sue you. No, so fast. If you are a person who's trained and you have a license, the family members of that patient and the patient could sue you because you did things the wrong way. You understand me?
Yes.
I understand, but it also makes me not ever want to stop and help anybody if I got into
But
that
then
situation.
again, and this is what I want to get to. In New York, that's why you need to know, as nurses, you don't only need to know the nursing clinical part. You need to know the laws on each of the states you work. You need to know this, because it's New York. If you don't stop and somebody actually sees you there, then you could be held liable. And in Florida, it's such a great area, because once you study the law, you realize, yes, I should stop, but then there are some other addendums that said that if I don't stop, it's not obligatory, but then you should, it's if you read the one in Florida, the language is made so you could a little bit escape responsibility in a way. That's what I was reading the other day when I was addressing this subject. But what everybody agrees on is that if you stop as a medical personnel and you help somebody and you do things the wrong way, the Good Samaritan law is not made to let you escape responsibility. You will be held responsible for it. The end of this is, if you're going to be a nurse, you need to know what you're doing. Simply as that. You need to know what you're doing. There is no ifs. You just need to.
Dr. Diaz, I keep on interrupting you today, but I'm like, I love this that it's Saturday morning and we're so fresh. The Florida Nursing Practice Act is posted on the MRU webpage, and it's a statute. It's a Florida statute. You probably have studied this in the past, and especially maybe while you were in fundamentals and ethics, but this is the guide, and every state has a different Florida Nursing Act, and that's the practice scope that you're allowed to have within that state. In order for you to protect yourself, you should know.
practice.
You have to know to safekeep your license so that you are not ever held liable once you start practicing. You need to know what you can do, what you cannot do, because there'll be times that are going to be gray areas in where, for example, a physician may ask you to obtain consent, and they expect you to explain things to the patient, and you cannot do this.
You should not do
The only thing you can do is
That's the
obtain a
weakness.
signature.
Weakness.
So Florida Nurse Practice Act, I can share it. I can share the link on the comments, and I will not interrupt anymore. I'm just
No, please, Dr. Acero, more than welcome to interrupt every single time. That's what we're here for.
yeah. I just feel that it's
And this is something that you need to know. For instance, going back to pharmacology, let's say the use of propofol. The use of propofol in the state of Florida, it's a subject. Can you use propofol in an ICU setting on an intubated patient at more than 50 mics? Can you do that? Huh? Would you be able to do it? Let's say you're doing a procedure and the physician tells you suddenly, increase that propofol. And that propofol, there is no CRNA in the procedure. It's a moderate sedation procedure on an intubated patient who came from the ICU already on propofol. So this is a maintenance. This is just maintenance. And you're doing your thing, and the propofol, it's at 30. And he keeps on, the patient is moving, and he tells you, increase that at 40. And you do. Increase that at 50. And you do. Can you actually keep on increasing the dose if you don't have a CRNA in the room?
I don't know, but I would assume not. But I
You
don't know.
can.
yeah.
More than 50, you get into the realm of anesthesia. And that will be, for you, illegal. Because you have no training to actually take care of a patient and more than that. Is it true or not? That depends, but that's the law. And that's what you need to know. If you're working in the state of Florida, you have to get on the link and know. And you will be getting questions in NCLEX related to this. And if you're doing UWall now, you're getting questions about this, right or wrong? Have you found questions related to this? You will. And you might not get a lot of questions in the NCLEX about this, or you just might. Now, if you make a mistake on one of these questions, the NCLEX is going to hit you hard, and it's going to ask you again. So you need to know the info.
Professor, I'm sorry
So-
I interrupt. Yesterday I took the CAT exam, and I have a question about two of the questions that I got. One of them included the Good Samaritan law. It was about a patient that she came with low respirations, a lot of pain. Blood sugar was, I'm sorry, the blood pressure was practically normal, 130 in the 130/80, something like that. But anyways, normal vital signs. The thing is that the patient was in a lot of pain, 8 to 10. So the nurse was supposed to inject morphine, but she injected way more, or double, something like that, than she was supposed to by mistake. Not right now, my love. Give me one moment. But then one of, but then after she checked on the patient, the vital signs were normal. The patient was not having respiration, depression, nothing. He was normal, and also the pain had subsided. So the patient was fine. Now, when it comes to the answer, I know two of them for sure were not the one, but the other two were about, is the nurse cover in the Good Samaritan law from this, or the other answer that I was also in the, is the nurse considered to be negligent and she can be liable for it or sue for it? So I
Right. So
exactly I
the
answer. I
Good
think I answered the
Samaritan
second
law,
one.
the Good Samaritan law. I mean, the patient. When you say the patient came to where? Where were you when the patient
ER.
came?
To the ER.
So you were in an ER.
Yes.
You're not being a good Samaritan. You're getting paid for it.
Okay, so it was negligent, and the nurse can be.
And you're violating one of the patient rights, which is right. Which one? Right dose.
Right. Yeah, I think I answered that one.
So you're not being a good Samaritan. A good Samaritan is a person who, without having anything to gain, it's doing something that it's commendable.
Oh,
right?
I understand. Something
That's coming from the Bible. That's coming from the Bible. It's you're being a good Samaritan when you stop and you help somebody without expecting anything in return.
I understand now.
That's where it comes from. Now, if you're in the ER, it's still commendable. I did ER for 11 years, and it's a hell of a job, by the way. It's a difficult job, but you're not being as specifically a good Samaritan. You're being a high-paying medical professional who's working, and you need to follow protocols, and you should know better than to actually give double dose to a patient. And if you were to do the right thing, you would have scanned the patient, you would have scanned the medication, you would have confirmed that 3 times at least that that's the right med, the right patient, and the right route. So you don't do any violations. So you don't violate dosing, so you don't violate patients, so you don't violate time, so you don't violate anything. Yes, you are liable if something happens to that patient, because by definition, a medical error is something that can be stopped, that you could have stopped before it happened. And double dosing is one of those things. Now, in the midst of craziness in medical settings, people try to cut corners. People try to do things and they do it fast. But there's things that you should not do ever. And that's why these days you need to scan the patient. You scan the patient, you scan the medication, you double, you triple check, because it should be 3 times, and then you give the meds. Now, depending on the amount of morphine this nurse gave, it might be just nothing, right? If you gave, let's say, 2 of morphine,
I think she
and
was
the other
supposed to give 2, but she gave 4 by mistake.
still wouldn't do it. I mean, most patients would not go into respiratory distress with 4 milligrams of morphine. Some patients get, for instance, 1 milligram of Dalare, which is equal to 7.5 to 7.8, dependent on the chart of morphine, and they still don't go into respiratory distress. So most likely this nurse was very lucky, but yes, she made a mistake. It's an error. It's called double dosing, and you are liable for it. Definitely.
Yes, I think I answered that question.
Yeah,
that
you are
way.
liable for it.
You can be sued for it. It actually said that in the question.
No, you can exactly. I mean, can they win the suit? They will have to prove intent. So I doubt it. But the patient could say, you could have killed me, and you'll be in big trouble for no reason, because you didn't actually follow the right protocol when it comes to medication administration, which you should at all times, guys. This is not a joke, especially with opioids. I mean, my students know that the wrong amount of opioids is going to do what to a patient, Lisandro, Beatrice?
Respiratory depression.
Right. Respiratory depression, respiratory rate. And that's a big deal. That is a big deal when it comes to patient safety. And not only that, pharmacy is going to be on top of you. Why are you giving 4 instead of 2? What was the reason? All eyes are going to go. I mean, all medications should be given carefully, knowing exactly pharmacokinetics and pharmacodynamics of the medication, side effects, interactions. This is what you study pharmacology. This is the reason why you study pharmacology. But opioids, benzodiazepines, stimulants, those are medication in hospitals that you should be very much aware, because of the stigma of the medication and the fact that everybody's going to be looking at you like, why are you giving 4 instead of 2?
Professor, I have a question.
Who is this?
Wilton.
Hey, how you doing?
I'm well, sir. Regarding of the question that previous student have at in the cat. Yeah, I know the patient was feeling well, but the nurse that gave the extra medication, does she have to put like an incident report still, or
She should follow protocol in the I mean, you don't put them in the chart, but there is a protocol in each hospital that you should follow. Yes, you should. Okay. I mean, first of all, they will realize right away what happened, because every single time you give opioids, you need to be accounted for it. Meaning, let's say you get out of the Omnicell or the Pyxis 2 of morphine, but you're only going to give 1. So after you're done, you need to waste that medication. You need to go back. You need to go into the Omnicell, the Pyxis. You need to enter the patient names. You need to enter the medication that you gave, the medication that you're wasting. You need to state a reason why are you wasting that medication. You need to put your fingerprint. A second nurse needs to come, and then a second nurse needs to put a fingerprint. So what happens if you're giving 4? There are going to be 2 milligrams of morphine unaccounted for inside that machine. So what's going to happen is that pharmacy is going to call you and it's going to tell you there is a discrepancy here. There's a big discrepancy here because you're supposed to have 2 more milligrams of morphine that you don't have. What did you do with that medication? What did you do with those other 2 milligrams of morphine? Because the last person who entered the Pyxis was you, and the last person who actually retrieved morphine from the Pyxis or the Omnicell was you. So you need to tell me what happened to those 2. They're going to call you right away, and they'll make a big deal of it. So yeah, you should just come forward. I mean, it's not only because it's the decent thing to do.
It's
to come forward and to tell the physician, listen, this is what happens, to make the report. I'm sorry, it was a mistake. And I'm here to tell you that I did this in the midst of whatever. People make mistakes. You should just come forward and let your supervisor know, let the physician know, and observe the patient carefully in case there is a pharmacological reaction
Professor,
with this patient. Yes.
This is the ethical principles that we study are so important. This is integrity. The integrity that you have as a nurse, and advocacy. You're advocating for your patient that you know you made a mistake for. So your integrity is telling you have to report this. Advocating for that patient is that ethical principle that you're going to be applying there, because the doctor needs to be made aware in case that patient goes into respiratory distress and needs rapid intubation. They need to be aware. Veracity of telling the truth. That's the ethical principle that is applied there. So
We
the
will.
ethical principles that we learn, we actually use them in practice and they become us. The RN lives by
By
those
their
ethical
ethical
principles.
principles. Do you remember when I used to tell you this? These are a bunch of words that right now don't mean a lot to you, but they will. You evolve as a person once you become an RN. Those fears, they go away. Yes, you make mistakes. We all make mistakes, and it's gonna be very difficult for me to tell you won't make mistakes at work. Please, guys, account for your mistakes. If there's no intent, if you didn't mean to do harm, which is one of your ethical principles, if you did not, if you did not mean to do harm, you have to, you'll be okay.
That is
Most,
non-malficiency. The non-malficiency
that's right.
Non-malficiency is the intent to do no harm, and beneficency is when you have to, when you want to do good. So it's all based on ethics.
And you have to follow those ethics.
Correct.
We've been in situation where we done stuff without, it's normal efficiency. We didn't want to do things. When we're done, we can, that's why you take consent. You explain the patient, this is what could happen, this is what could go wrong, this is what you're facing. And then after the procedure or after what you do, whatever, you have to explain the patient, listen, this is what happened to you because of what we did. You don't hide it. Just because nothing happened doesn't mean that it has to stay hidden. It should not stay hidden. Many reasons why it should not, guys. We learn from our mistakes in the hospitals. That way we can set up protocols. That way we can change what's leading us to make those mistakes. And I gotta tell you, most of the time, it's not the nurse's fault. It's not. Most of the time, it's the mistakes are happening because of the way the protocols are set up inside the institution. And if you come forward and you tell the hospital, the doctors, the supervisors what's going on, we might be able, or they might be able to put into place new protocols that at the end are going to help you. They will help you do better at your job.
Professor, it's Margarita again. I'm sorry to interrupt. Now that you're still talking about protocols and ethics, I also remember about a question. It was this patient that was going to have a hip replacement or something like that, big surgery. So he had already been injected with the first medication to, I'm sorry.
Go ahead.
Para poner al paciente down in surgery. He had already been given the medication, the first medication. It's just something like that. And so now, but the doctor forgot to sign a consent with the patient. So he went rushing before getting the patient into the surgery to have the patient sign the consent, and also ask the nurse to witness and to sign also the consent, of course. The options were bring this to the attention or report the doctor with a charge nurse, or I know the options were not right, but the other option was reschedule the surgery. I answered reschedule the surgery because what I know about sign consent, and when you're with these opioid medications, you cannot get consent from that. So I answered reschedule the surgery, but still, it's
So
it's very gray area.
the thing about this, Margarita, is this. The main point here will be, is this a surgery that can be rescheduled?
I guess, yes. It was a hip replacement. I'm not sure. I guess.
Is it a
It
surgery
depends
that
on the
can actually?
urgency of the situation, right? Like how emergent it is.
Yeah. Is it so? If it can be rescheduled and your patient already got anesthesia, and by that I mean a dose of benzodiazepines to induce anesthesia, barbiturates, and your patient is not right, and the patient is not consentable at that time because of the medication the patient got, you got two choices. You can either reschedule this procedure if it's possible, and you will have to face the patient and let him know that you did not consent him and he needs to go through the whole process again. If it's an emergent surgery, you could always get two doctors and nurses to come and do it medically necessary. But then you're doing this procedure in medically necessary because of the physician, because he did not consent the patient. What you shouldn't do as a nurse is to sign that paper, because you're not responsible for explaining the procedure. You're just a witness. The explanation of a procedure and the consent, it's given to the physician who's doing the procedure. Is that understood?
Yes. One of the options also was to inform your charge nurse and pretty much report the doctor.
It's not that you're reporting the doctor, you know, it's what are you gonna do? You're gonna go against state law and you're gonna violate the patient's right?
No.
You know?
Because then you're reliable too.
Then you are. So we've been talking about this for a while now, right? Look, it's here in my PowerPoint. These are nurses' legal responsibilities, that right? So you need to have knowledge of federal, state, nurse practices, and local laws. Not only that, you need to look at your healthcare facility policies. You need to look at how they go forward with the prescribing, dispensing, and administration of medication protocol inside the facility. Can you guys see me? I seem to have lost.
We can see you, but we cannot see your PowerPoint.
You cannot see my PowerPoint? I actually lost. That's weird. I lost contact with you guys for a minute there. Let me see if I can reshare it. Can you see it?
Yes.
All right. I'm sorry about that, guys.
Excuse me, Professor. At the end, can we have this PowerPoint?
It's not, I can send you this. Yes, you can. The short answer is yes, you can. The long answer is that there are only 35 chapters in this PowerPoint out of 56. So I'm going to continue adding to the PowerPoint. More than happy to send it to you guys. More than happy to send it to you. I think it's a good way to study, and I will send it to you. But know that by the end of the semester, I mean, the PowerPoint's going to be somehow different because I'm going to add more and more and more to the PowerPoint.
Excuse me, Professor. I have a question.
Go ahead.
I am at my last semester. I'm not graduate yet. But can I use this PowerPoint to prepare my final for the semester?
Can you use your what?
This PowerPoint.
To do what?
To prepare my exit, like VATSI, Porto, I don't know what I have to do for the.
Well, if you're asking me if the PowerPoint is up to code, let's put it this way. Yeah, it is. It's factual information from pharmacology from Lily's 9th and 10th edition. So if you're talking about whether the information in the PowerPoint is totally correct, yes. Who is your professor?
No, I have Laritza. She's doing integration for me, and I have Antoinette, and
They are both using the same information that I use. So you have two wonderful professors. You have two marvelous professors right there, and Larixa is an example to follow. So she's a great professor. So I'm pretty sure that you could use any of this information to actually study for anything. Remember, this is not everything that's in the book. This is a PowerPoint made for you to summarize and to address key points. I don't know what Dr. Larissa is going to ask you in her exam, and I'm not taking any responsibility for any kind of information that might be on your final exam that is not in my PowerPoint. That being said, you can use the PowerPoint at your own leisure whenever you want to. I'll send it to you.
Thank you. No problem. Thank you so much.
All right. So guys, you need to have knowledge of federal, state, nurse practice, local laws, healthcare facility, especially facility protocol change all the time. For instance, we used to use Cerner at my facility. Now we're using Meditech. So a lot of the protocols that we had in Cerner are different in Meditech now. Internal protocol. Now, the internal protocol of the facility can never supersede state law or federal law. You still have to follow federal, state law, and nursing legislation. That's why most of the protocols inside the facility are going to be adjusted to state law, federal law, and nursing practice law in the state where you are practicing. Is that clear? Come on, go talk to me, guys.
Yes.
Yes.
Are you guys asleep?
No.
Good.
Oh, we're here, Professor. We're here.
Good. I don't want anybody sleeping on Saturday. No way. Sleeping is for winners. We gotta get this done. No sleeping. So preparing and administering and evaluating response to medication, it's also part of your nursing responsibilities. You know, like we were saying, if you were supposed to give 2 and you gave 4, you prepared the wrong medication. If you were supposed to give 2 and you gave 4, you actually administer the whole medication. Look at how many nurses' legal responsibility you're breaking there. And then afterwards, you probably actually stood there to see the responses to the medication if you're smart. But this is what it is. This is not only an ethical situation. This is a legal situation that you have in your hands when you're not following patient rights, by the way. The other thing is developing and maintaining an up-to-date knowledge based on medication administration. Oh, but we already know the meds. No, that doesn't mean that does not mean that the rules of engagements are going to stay the same forever. Right? That's why we have phase 4 when we're developing medications. Things are going to change throughout the years. It is your responsibility. You might have been using this medication for 20 years as a nurse. If new developments about the medications come into light, you need to know this. You need to know this. If something changes, new side effects, new allergies are coming into light, you need to change that. That's why it is your responsibility to stay up to date with new data. Nurses, physicians, nurse practitioners, they don't stop ever learning. That's why Alzheimer's doesn't touch us, because our brain goes like shh. Forever and ever. You need to maintain knowledge of acceptable practice, of skill competence. You need to maintain knowledge of the developments that these medications may go through, right? It doesn't even stop there. You know, if a doctor calls you and tells you to do something and you don't understand, what do?
We clarify.
Clarify.
How do you clarify?
Tell them you don't understand.
It's called what? Call back. You call them and you tell them, listen, I don't understand this order. Are you sure? If you get a order that it's handwritten, which is not what we do these days, but it could happen, and you don't understand the order, what do?
You call the doctor back.
Call back the doctor to get clarification.
Right. If your patient is supposed to receive medication for seizures, PO, by mouth, AM, and the order hasn't been changed to IV, can you change it to IV, or what do?
No, you have to.
No, you cannot
call the
change.
doctor.
You have to clarify.
You have to clarify. It is your duty. It is your duty to actually determine and follow medication accuracy. You need to know what you're doing. Even if you know the answer, your scope of practice will tell you you get until here, and from then on, it's somebody else's job. Let me call. Why? Because we know that medications don't behave the same way by mouth that by parenteral, right? Doses are not the same. It's not the same 20 milligrams of lisinopril that 20 milligrams of Vasotec. They are the same medication, basically. They're ACE inhibitors. But how much would you give a Vasotec, for instance? A lot less. Why? What happens when you give medication PO?
It takes longer to
Why?
get
Why
a
does
reaction.
why does it take too long? Why does it take that long?
It has to
It
go.
has
Because
to
of the
go through the
absorption
digestive
process.
system.
Right, it goes through the digestive system, and from then it goes to the small intestine, and from then it gets attached to carriers, and from then it goes to the liver, and from the liver it goes to the first pass effect, and from the first pass effects it gets changed through the action enzymes, and then it gets into the bloodstream, right? That's the fast way of doing it. I mean, this is very simplistic, guys. You know this. So you need a big dose PO. Whereas if you put an IV, what happens with the bioequivalence of this medication?
It's immediate.
It's 100%. So if you are a new rookie nurse and your professor of pharmacology wasn't a very good one, which doesn't happen at MIU because we have the best, except me, of course, the best pharmacology professors in the States. So guys, if you're a rookie one and you give 20 milligrams of Vasotec to your patient will die. That's why you don't take the risk. You know the accuracy of the medication, and you call and you double check and you triple check with the physician who ordered this. You don't send the patient down without the medication. You do your due diligence, and then you change the order. He changes the order, or you change it for him, and then you read back. This is what you want me to change, right? Yes. You put it in the computer, and everybody happy, right? You report medication errors. You don't have to be afraid, guys. They're not out to get you. They might tell you, listen, this is what happens. You might get a report, but they're not out to get you. Hospitals are not out to get you. They want to their protocols to be as accurate and as safe as possible, right? And you have to save water and study medication in the right way, whether it's temperature and privacy and in a legal way. Any questions with nurse's responsibility? No?
As nurses, we have to know the doses for each medication as well.
Oh my, if you're giving a medication if you are putting this medication inside the patient's body, you need to know everything about that medication.
Okay.
This medication wasn't prescribed, Valdes, by a perfect person. We're all humans. We all make mistakes. If you were to be a robot or an assistant, you would just follow an order, but you're not. You're a registered nurse. That's the reason why you're here with me today. You're a registered nurse. You're a person with a license. You do not work for a physician. You work with a physician. That's why you follow all of these nurse practice acts and the laws and so forth, because you have your own license and you're liable for what you do. And you need to know the meds. You need to know the pharmacokinetics of this med, the pharmacodynamics of it, the generic name, the trade name. You need to know. You need to know the dosages of this. You need to know the possible side effects of the medication. You need to know how can they actually, basically you need to know everything. That's the way it is. It's overwhelming at the beginning. It is. With time, you got help. You learn more and more and more and more, and in your setting, you little by little you get to know everything you need to know. It's called experience. That's what it is, and don't be afraid. We all get there, and even after 20 years or 20-something years doing stuff, you still find some medications and some procedures and some situations where you're actually lost. What do? At that time, you learn from the person next to you, and then after that, you go back to study. And you do developing and maintaining, which is one of your nurse's legal responsibilities. You go back and you study the whole thing.
Okay, thank you.
So if you're a nurse and you get a prescription, you need to know this. The prescription needs to have the client's name. It needs to have the date and time of the prescription. You need to know the name of the medication. It has to be there. The dosage of the medication, the route of the medication, the time and the frequency of the medication. And it needs to be signed, usually electronic, by the physician. And if you're the one entering the order, which is a verbal order or a telephone order, they have a certain amount of time according to hospital protocol to sign this prescription. As a nurse, you're not supposed to put orders without a physician telling you, unless there is a approved medical protocol that it's already been approved, and you should pull this protocol from the system, open the protocol and sign the protocol. And then that counts as a medical order, and the physician needs to co-sign the protocol after the procedure. You still have an order. It's just a protocol order, but it's there. You're not supposed to, as a registered nurse, give medication without a prescription. And if the client's name is not right, if it's Hansel Diaz and it says Hansel Gonzalez, because registration messed up, you need to change that before you start doing whatever you're doing with the patient. Because Hansel Diaz is not Hansel Gonzalez. It might look like the same ugly guy, but it's not. You need to change it. If there's no date in it, no ticket, no laundry, my dear. It's not happening. If the
Yep.
dosage are lost, if it doesn't say PO, IV, intradermal, sublingual, buccal, it's not happening. It's just not happening. You call back. You call back your doctor right away. Doctor, listen, we need to do this fast. Can you please tell me what you meant here? Most of them are going to be very appreciative of what you're doing. They're going to go like, oh my God, sorry. Can you put it in? Or do you want me to edit the order? I'll do it for you right away. And then having a great nurse, it's everything for physicians and for nurse practitioners. Having a nurse that is knowledgeable about what they're doing, it's half the job, guys. It's just half the job.
Yep, Professor Diaz. And sometimes we get a patient whose identifier number is wrong, and that was an issue from admission. And then as a nurse, you're like, why do I have to call admission? Why do I have to do this? Sometimes you don't even have to. It's not about calling the doctors, the admissions department that made a mistake, and you have the same name of a patient, but the ID is wrong. And so it's your responsibility to actually fix this because you're advocating for your patient.
He is yours.
Mm-hmm.
It's called primary nursing. Once you get him, he's yours. He's your dad. He's your mom. He's your kid, your uncle. No sympathy, empathy. Get in their shoes, feel it. This is what I do. This is my responsibility. I have to do what's best for this patient. Like if I were doing this for my own mom or my father or my sister or my brother, like if they were part of my family. The only difference, if you are highly trained medical personnel who's going to do things following protocols and who's going to do things following proven science. But you're still going to do things like if they were your own family. It's your responsibility. You never give the extra mile as a nurse. You are expected to give the extra mile. That's what you do. That's your job. If you go there for a paycheck, there are many ways of getting money, guys. A bunch of ways of getting money. Nursing is not one of them. You're there to help people, and you're there to help them in a way anybody else, other people can't, because you're trained for it. So yeah, responsibility, it's a big deal. When taking a verbal or telephone prescription order from healthcare, you have to make sure that includes all of the above, like that little paragraph says, otherwise it's incomplete. And when you're done taking the order, you know what you do? Let me read it back to you, Hansel. Oh, come on. Come on, Dr. Acevedo. Are you crazy? You're reading all this back to me? Now, I don't have time for this. If you want me to push the button, I need to read that back to you. Let's just do this. And then you read back the order quick, and then you mend this. And then by reading back, you might find out that there is a mistake somewhere there. And you change it. Okay? Questions about this, guys? You good?
Good.
So, how do you like this? Oh, come on. Don't give me this silence.
I don't mind those calculations. It's fine.
You know what? This is simple math. This is simple math, guys. This is not a big deal. Guys, I wonder if you guys want to take a few minute break. Maybe 5-10 minutes.
I'm good.
Not really.
Huh?
Yeah, I'm okay. I
Okay.
personally am okay.
Then we're good. I don't care, guys. I have water, my computer, so I'm a happy camper. My students know I don't like breaks anyway, so. Is Yoan here with us?
Let me go ahead and get him. 1 second.
Yes, Professor, I'm here. I listen to you.
No, I meant
Professor Valdes.
I meant Professor Valdes. I'm sorry, I should have addressed Professor Valdes the right way.
I believe he's engaged in a class.
Okay, so let's do this anyway. Guys, like it says there, math is just mental abuse to humans, and most of us don't like it. Do we use it in a hospital settings? Of course we do. I mean, how are you going to measure medications without actually making calculations? Most of those calculations are very simple. And they can be made, some of them from the top of your head without using a calculator. But you still need to know this for the NCLEX, and you're still going to get questions in the NCLEX related to calculations. And even most important than that, you will have to use it at work. So this is simple math with something that we call equivalences, and that's what you need to know. Due to the fact that we have the metric system and we need to know how to calculate. For instance, most of the patients in South Florida will give you the weight in what?
Pounds.
Kilograms.
Pounds.
Huh?
In pounds.
In pounds. Can we actually calculate medication administration in the state of Florida in pounds?
No.
No.
How do we calculate that?
Kilograms.
In what?
Kilograms.
In kilograms. So if I tell you I weigh 198 pounds and you're going to calculate heparins at 70 units per kilo, how many kilos are you gonna, based on what way are you going to calculate that heparin administration?
Divided by 2.2.
You have to divide, right? 198 between what?
2.2.
Right, how much is that?
90.
Let's do it. 198 divided between 2.2, that's 90 kilos.
90.
Times 70 units. So I'm administering 6,300 units of heparin, right? Now, if you make a mistake and you confuse pound with kilograms, 6,300, it's a lot of heparin to administer IV push, by the way. Now, if you do 198 times 70, you'll be administering 13,860 units of heparin. Never, ever, ever, ever administer medication based in pounds. This is nursing 101, pharmacology 101. It has to be kilograms, always. So if the stem of your question tells you this patient has 190 pounds and is asking you to calculate medication administration, right there, you know, they are not giving me the whole information. What do you need to do before you do anything? You have to convert pounds to what?
To kilograms.
to kilograms. You have to convert pounds to kilograms. And if the answer has to be in milligrams and what you have is grams, what do?
Convert gram in milligram.
How many milligrams in 1 gram?
Meal 1,000.
1,000.
1,000. And if it's an if you have 1 liter, how many milliliters in a liter?
1,000.
1,000 milliliters.
That's right. And if you have milligrams in your, and you want micrograms, mics, how many mics in 1 milligram?
1,000.
1,000, the same thing. And if you have units and you want milli-units, 1,000. And you have to remember stuff like 1 liter of water is 1 kilogram, 1 milligram, it's 1 gram, and so forth, right? So, right there, can you see this, guys?
Yes.
So right there you have your most important equivalents. Weight, grams, milligrams, micrograms, volume, milliliters, or cc's. I lost you again. Anna, you lost the screen, right?
No, we can see.
No, we can see you.
You can see me, but can you see the screen?
Yes.
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 So I don't know what happened there. I might be
We see
having.
it.
Okay, that's great. So it can get simpler than that. Formula to how much to give. So if the order says coumarin 7.5 milligrams and you have available 2.5 milligrams, how many tablets would you give to the patient?
7.5 divided by 2.5. 3 tablets.
3 tablets.
That's right. So what you want, goes on top, right? Let's see if I can do some sort of a. I'm trying to see if I can add something here. So what you want goes on top, 7.5. What you have goes at the bottom, right? And right here, we're talking about tablets, not milliliters. So you divide 7.5 between 2.5 milligrams times 1, that's 3 tablets, right? Do you have a question? Do you have doubts with this kind of formulas?
No.
Are you guys sure? This is not the time to, if you have a question, please, guys, if I can help you, I will. If Professor Azareto can help you, she will. We're all here to help you. So if there's something that you don't understand, just come forward. You can tell me, look, I've been studying this for 4 years and I still don't understand it. Is there any magical way you can show me to understand it? And I will try to help you as much as I can. I'm not a mathematician, so I might not be the best person to teach you how to do math calculations, but I will try to help you understand this. Do you guys understand this formula?
Yes.
Because this is the main one, Marie. This is the one that we use the most.
Yes.
This is the one that we use the most. Why? Because we have this little guy here. You see what this is? Can you see the arrow? Most hospitals, that's something that's called an IV pump. So most of the time, we use an IV pump in the hospital. And I mean, if we have an IV pumps are smart. They have a brain, how we call it, and then you can do your calculations through the IV pump. But the formula, these little calculations, you need to know them, and you don't use for IV push medication, IV pumps. You do it, it's called IV push. So you need to know how to calculate, right? So in this case, let's practice. 1,500 milliliters of normal saline to pass in 15 hours. That's a simple one, right? That's a simple one. What do you do in that case?
1,500 divided by 15.
That's right. And that will give you how much?
100
milliliters per hour, right?
Yes.
So that's really easy. The problem is when I want to infuse something in less than an hour. That's when the issue comes. Because if you want to infuse in an hour, all you do is just divide by the amount of hours. That's easy peasy. But let's say I want to infuse 100 milliliters of that solution in 15 minutes. What's going to happen to the rate in that case?
You have to convert hours in minutes, no?
Right, but what's going to happen to the rate of the infusion? Is it going to increase or decrease?
Increase.
Right, because you want more in less. You want a lot more in less time. Before it was 100 in an hour. Now you have 100 in 15 minutes. It means in less minutes, you're going to infuse the same amount of milliliters. And then now you have to play with hours and minutes, right? So you have your 100 times how many minutes in an hour?
60.
60. Now you want to infuse that in how many minutes? You're
15.
cutting that hour in 15 to 15 minutes. So you have to divide that hour amount, the 15 minutes, which is your actual target time, right? Is that understood? Hello?
Yes.
So in math, what do you do first? The parentheses or the multiplication outside?
The parentheses.
Right, so it's 60 divided between 15. How much is that?
Oh, 4.
And then if you multiply 4 times 100, which is what you have in your piggy bag, which is what you have in your little bag, the infusion you're going to put in, if you multiply that by 100, how much is that?
400.
400 milliliters per hour. In order for you to infuse 100 milliliters per hour into a patient, in 15 minutes, you will have to have a rate of 400 milliliters per hour, meaning your infusion has to go real fast. Because you have to infuse inside that vein 400 milliliters in 15 minutes, whereas if you wanted to do it in an hour, it will go slower. Is that understood?
Yes.
So that's not difficult. That's just one formula. And you know this now. If I want to do it in less time, and if I want my target rate to be 400 milliliters, what I have to do is to have to divide hours between target time, which is my minutes. Any questions with this? Huh?
No.
Okay.
No. Oh.
Good. So we can go to the other one, right? This is the one everybody's afraid of, right? Nobody likes this one. So we have drips. And then we have different type of lines. Some are micro drips, some are regular lines. So drug factor, it's a number. It's the number of drops that when you add them all, they go to 1 milliliter. Tell me you understand this. These many drops add 1 milliliter, and that's called drug factor, which is also called DF. Tell me you understand this.
Yes.
Okay, so usually I will give you, the professor, the question will give you the drug factor. If the drug factor is not given at all, there's a constant, and it's always what?
60.
60. So if I tell you to practice 500 milliliters of D5W to pass in 6 hours, and the drug factor is 15, you're going to use 15 as your drug factor, right? But if I don't give it to you, if I play slick, and I don't want to give it to you because I want to actually know if you know this, and I don't give you the drug factor. Which one is your drug factor?
60.
Is 60, right? Is that understood so far?
Yes.
So let's do this. 500 milliliters of D5W to pass in 6 hours. And your drug factor is 15. Calculate drops per minute. And the formula says GTT divided between minutes. What's GTT, by the way, guys?
Drops.
Drops. In Spanish, it's really easy for people in Spanish because GTT, it's gotas. So as soon as we see it, we go like, oh, gotas, drops per minute. Oh, they want me to do it's the formula of drop per minute. Okay, I have an idea now of what they're asking me here. They're asking me drops per minute. That's what I need to calculate. Now in English, gotas is not drops, and gotas, one have nothing to do with the other one. So you need to know that GTT divided between minutes equals the total volume divided by the minutes time the DF. So how do I do that now? Tell me. So what's your total volume there in that question? How much do you have in your bag? What's your total volume?
500 mLs.
So you have 500 mLs, and that is divided between the minutes. But to get to the minutes, you need to add the hours, right? Because you want it to pass in 6 hours. So now you're not dividing, you're multiplying. It's 6 hours between 60 minutes because you want it to go by minutes, not by hours. That will give you a number. And that number, you're going to multiply it by the DF, and that will give you an amount of drops per minute. Now, in this case, it's 20.83. What happened with 10? Can you leave it at 20.83?
No, you're gonna have to round it off to
because there's no way, even if you wanted to, how are you gonna cut a drop? You can't do that. You can. You have to round up, right? Is that understood?
Yes.
Yes.
If you were to get a problem like this, would you guys be able to do it?
Yes.
Rounding rules. So I'm asking you to round. Find the place value you want to round to the next or the nearest. That's the first thing you got to do. So I'm going to tell you, where do I want this to be round? At a decimal point, and so forth. If the number to the right is less than 5, the rounding number does not change. So 25.3, would that change at a decimal point?
Like 25.4.
No. I'm
No.
asking you,
No.
I'm not asking you to round the 3. I'm asking you to round the 5.
25.
No,
It will
it's
Same.
the
change
same.
because
It's the
it's lower than
25.
5.
Right. If the number to the right is greater than or equal to 5, then round the target number up, right?
Yes.
Round when the questions ask to round. If they don't ask you to, unless it is a drop, you don't need to. If the question tells you to round, you round. If the question doesn't tell you to round, you don't round up. And you always round drops. Always, because, I mean, you don't have a choice, guys. You can cut a drop, right?
Right.
All right. Questions about this? All right, guys. So I'm going to take 5 minutes. I need to go to the restroom. And then if you guys are for it, we can go to pharmacological principles. Is that okay with you?
Yes.
All right.
Yes.
See you in 5-10 minutes, okay?
Okay, Professor.
All right. All right, guys, I'm back. Are you guys here?
Yes.
Yes, Professor.
So, guys, start asking questions as soon as we start with this part of the presentation, okay? If there's something that you don't understand, ask questions. Every science has principles, right? Is that understood?
Yes.
It's a way to understand. So it's a small video. I'm gonna play it, okay?
Yes.
After swallowing an aspirin tablet, it will go on a journey through your digestive system. Absorption. The tablet will travel down the esophagus into the stomach, where it is dissolved into much smaller particles. These particles will continue their journey into the small intestine, where most of them will be absorbed into the blood. The small intestine walls, also called lumen, are lined with tiny villi which stick out to provide a large surface area for the nutrients inside the food to be absorbed. Looking closer at these villi, you can see they have a rich blood supply and they are covered in a thin layer of epithelial cells. The aspirin molecules will work their way through the epithelial cells and into the bloodstream, where they are carried around the body. Distribution. Blood plasma contains complex molecules called albumin. Albumin is a protein made by the liver which transports nutrients around the body. Albumin also binds to drugs that enter the bloodstream. Here you can see some of the aspirin molecules binding to the albumin. All the aspirin particles that have been bound will be filtered out as they pass through the liver, and only the remaining aspirin molecules will get through and have any effect on the body. Different drugs will bind to albumin in different amounts depending on their affinity for plasma protein. The next stop on the journey is the liver. The aspirin-rich blood will enter the liver through the hepatic portal vein at the bottom, and it will exit at the top via the hepatic vein. At this stage, even more of the aspirin will be removed through a process called first-pass metabolism. The liver's job is a bit like a filter. It will metabolize drugs before they reach the rest of the body. It does this in a few steps. Phase 1 metabolism. First, aspirin is hydrolyzed, breaking off ethanoic acid and leaving behind salicylic acid. This salicylic acid isn't water-soluble, so it can't be excreted in urine yet. Phase 2 metabolism. An ionized group is then added to the salicylic acid, forming glucuronide, which is water-soluble and can be excreted in urine. A lot less of the aspirin will continue its journey onto the rest of the body, including the site of the pain. Only 68% of orally taken aspirin will have any effect at all, because of all the filtering that the body has done. This percentage is called the drug's oral bioavailability. If drugs are not administered orally, e.g. intravenously or buccally, then they can bypass the small intestine and liver, so none of this filtering takes place, and they have 100% bioavailability. We are now at the site of some skin tissue damage. Tissues in the skin are creating prostaglandins, which are causing inflammation. The prostaglandins are sending messages to the nerves in the skin responsible for the sensation of pain. Once the aspirin arrives in the blood supply at the site, it prevents the production of prostaglandins in the tissue, which will reduce the swelling and stop the messages being sent to the nerves that are perceived as pain. Excretion. Any remaining aspirin in the blood will go round and round the blood supply, going back through the liver several times until it is all used up or filtered out of the body. It travels into the kidneys and then into the bladder for excretion.
So, what do you think? Hello.
The video explains the pharmacokinetics pretty well, like of the drugs.
It's pretty good, right?
Yeah.
It does explain what the body does to the drug. How do you absorb it? How do you distribute that? How it gets metabolized in the liver by the P450, and the way you get rid of whatever it is that you have left after the half-lives, right?
Right.
So basically, you drink it, or you shoot it, or you put it under the tongue, which is called what? Under the tongue?
Sublingual.
Sublingual.
Sublingual. Or you put a buccal, which is called what? How do you do a buccally?
And the cheek.
In the cheek, right? And then you can. There are many ways of absorbing a drug. Transdermal, mucosal, sublingual, buccal, rectal, enteral, or PO. Any parental way that it could be sub-Q, intradermal, intramuscular, IV. And there are some others that we don't really use that much as nurses, such as intraosseous or intratracheal or endotracheal, which sometimes we do. Those are all the ways we can absorb a medication. Some of them will bypass the liver, and if that happens, then your bioavailability is going to be 100%. Some of them won't, and they will have to go all the way, and they will be metabolized by the liver. And that's the reason why IV dosages are small in proportion to PO dosages, right? Remember when we were talking about the fact that you give 1.2 of Vasotec, whereas you give 20 milligrams of lisinopril, right? It's a larger dose of the medication if you do it PO because of the absorption of the medication. So distribution, you transport, let me get there. You transport the medication to the site of action by bodily fluids. Albumin being the binding protein, the one that we use the most. And just remember, two medications can compete for the albumin, and then that can result in toxicity. As part of distribution, you have the barriers, such as the BBB, the placenta. And remember that medications that are lipid soluble or have a transport system can cross the blood barrier at the placenta. Any questions with these guys? I'm just going to keep on passing, okay? It's too much information. Any questions?
It's okay.
No.
You don't have any doubts with this, right? I mean, we're not really here to go to, I'm not even here to teach you everything. It's just, we go through it. If you understand that, fine. We keep on going, okay?
All right.
So metabolism, primarily in the liver. And remember, when we're talking about kids and we're talking about older people, there is a different in dosages because of the decrease in metabolism or because of the development of organs, right? Steady state of a medication that doesn't have half-lives. Is that understood? So excretion
Can
is
you repeat that?
Okay, so you have a steady state medication. Let's wait until we see this. I wanna show you. Okay, what's a half-life, guys? What is it that the concept of half-life for you? What does it mean? What does it mean? What does that mean, half-life? Can somebody tell me what that is in pharmacology?
The time it takes for the medication to like reach half of the amount it has.
Right. After an oral medication has been absorbed, most of the medication, it's the PO medication, it's inactivated. We saw it with the aspirin, right? And then it goes into the liver and there is change. This is what we call first pass effect. So after that happens, the medication gets into the bloodstream, and let's say you took 40 milligrams of X medication. After if I tell you that the half-life of that medication is 4 hours, what happened after 4 hours with that medication?
20 milligrams will be left.
20 milligrams, which is half of the original dose.
Right.
And then after 4 more hours, what happens?
The medication is excreted.
The medication, no.
Oh, wait,
10.
no.
10 will be
yeah,
left.
right,
It's
right.
10. And after 4 more hours?
It'll be 5.
5.
5,
And after 4 more hours?
2.5.
That's right. So about 5 half hours, it's what the medication is supposed to stay in the body if it's absorbed systemically, right? So you have something that's called steady state, right? It changes the medication by the action of enzymes. So are they medication that are not absorbed systemically? Do you know of any medication that is not absorbed systemically? That you drink my mouth and it actually, it is not absorbed into the body and goes systemically. Do you know any of them? Have you heard about this? Come on, Beatriz, Andrea, Daniela, talk to me.
Nitroglycerin.
So let's say there are some antibiotics that are not absorbed systemically. Cefaxin, for instance, is one of them. So you drink it, and it gets once it gets into your stomach, it gets into your small intestine. It doesn't actually leave it; it stays there. It's not systemically absorbed, and it's excreted in its completely. So you take 400, and after a certain amount of hours, 10 or 12 hours, it goes out in its entirety. That's what we call steady state. It stays steady. It doesn't change. Does that answer your question?
Yes.
So excretion goes primarily through the kidneys. It decreases in the elderly and renal disease. We know this. Come on. If you're old and if you're having renal problems, what's going to happen to the excretion of the medication? It's going to decrease. That's why we have what we call renal dosages. Because you will have more free meds in your body if you're an old person and if you're an elderly person, and therefore you get less medication, basically. After an oral medication has been absorbed, we already said that, it goes into the blood and then it passes through the liver, it produces a little therapeutic effect that is called first pass effect. Questions with that?
No.
Drug half-life. Time to take for the amount of drug in the body to decrease to 1/2 of the peak level. used to predict those schedules and duration of effect. That's what we say. It takes 4 hours for this drug concentration to fall from 50 units to 25. So a half-life in 4 hours. So we know by doing our research, our due diligence, and if in 4 hours, half of the drug is out, the concentration went from 50 to 25, the half-life of that medication will be 4 hours. Now the study has been already done for you. You will be given half-lives all the time. Like fentanyl has a half-life of 3 to 5 minutes. So you know that in 3 to 5 minutes, half of the medication is going to be out of the system. The half-life is short. Phenobarbital, on the other hand, has which is a barbiturate, it has a very long half-life. So you know that it will have to take hours and hours and hours for that medication to actually leave the system, to decrease its concentration to half of what it was initially given. And that's what we call half-life. Good?
Yes.
Yep.
Some cells have specific receptors which can be stimulated. So with those cells and those receptors, when you stimulate them, that medication is called a what? Let's go back to this because this I want you to know. If not all the cells, but some cells, they have very specific receptors that when you touch them, they can be stimulated. When you stimulate a receptor, it's like opening a door. You're stimulated by doing what? An agonist stimulation, right? When you inhibit that receptor is an antagonist. That happens with chemical drugs. An example. Any one of you give me an example of an opioid. An opioid medication. Come on.
Percocet.
Come again? Wilton.
Percocet.
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 Percocet. Or let's add some more. Hydromorphone, Dilaudid, or morphine. Any one of those are agonist medication. They will go inside the body and they will stimulate a receptor inside a cell to produce an action, which most likely will be what? The relief of pain with time, right? So what happens if I'm stimulating that receptor too much? And as a consequence, I start getting side effects of this medication, which we know that one of the most common side effects, and at the same time, one of the most dangerous ones will be which one?
Respiratory depression.
Respiratory depression. So if we're having too much respiratory depression due to the fact that this patient consumed or we getting too much opioids, how do we make that cell that is being stimulated by agonist chemical stop? What do?
Give the cell an antagonist.
We give them another medication that is called an antagonist. And in the case of an opioid, which one would be the antagonist?
Naloxone.
Naloxone. Or Narcan, right? It's like a door with a keyhole. I always tell this to my students. You put the key inside, you turn around, and you open the door. That will be an agonist. But if you want to make sure that door stays closed, you put the key in and you close it and you leave the key there, there's no way nobody can open that door again because the keyhole, it's already it's been used. It's being used, and the key. If you don't move the key, then the result won't happen. The door won't be open. That's basically agonist and antagonist. Do you guys understand that?
Yes.
So the interaction with the receptors, it's what we want to achieve when we do this. It's a change in the cells. That it's the intention is to be therapeutic. What's therapeutic? What do we mean when we say therapeutic? How are
Have the
drugs?
desire.
How
You
that?
have the desired dose to keep the patient within the interval that you want, you know.
Right. You want to
To
alleviate.
achieve the things
The
that you want with
effectiveness
this
of the
medication.
drug. The
You want to
effectiveness of the drug.
alleviate. Right. You want to alleviate an issue. If you have a headache, you want the headache to go away. So if the medication is therapeutic, then it's resolving that issue. It's being used to stop a headache. If you're having seizures and you want a therapeutic medication, you would use a benzodiazepam to alleviate the seizures or to stop the seizures, right? If you that's what we call therapeutic. It's basically the effect that we want to happen. That's what we just said, what we were saying. These are all the types of drug administration: intramuscular, intravenous, oral, portal circulation, first part effects, blah, 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 blah. Let's go to what we're here for. What do we do before we administer drugs?
Ask for allergies.
Take vital sign.
What do we do?
Assessment.
What do we do before?
Assessment.
What do we do before all that?
Check
We
if
take the vital
it's the right
sign.
Assessment.
patient.
Vital sign.
The right patient.
Identify the patient.
Check the ID of the patient, name.
What do we do before we check the ID of the patient and the name?
Check the dog.
Check vitals.
Any error?
We check
Man, nobody watches their hands here?
of
Assessment.
course.
Then you watch your hands.
Get in the room, wash hands, and then check the
You watch your hands. You go,
file.
happy birthday to you. Happy birthday to you. Happy birthday, happy birthday, happy birthday to you. And then you go again. Happy birthday to you. Happy birthday to you. Two happy birthdays to you, right? That's the first thing you do before you go see a patient. You watch your hands. Why am I saying this? Because this could easily go into one, all of that apply and some stuff like that, right? If you do BSIMS, have you done BSIMS?
Yes.
The first thing you do is to tell you, watch your hands.
Wash your hands.
Watch your hands. You ask the client for allergies. Of course you do. You're going to check the original prescription. You're going to check the medication. You're going to reconcile. You're going to go to the MAR. But before actually looking at the patient, you're going to wash your hands. Is that clear?
Yes.
And then depending on what you're giving the patient, then you're gonna know what is it that you need to know, right? If it's digoxin, for instance, you're gonna check apical pulse. If it's a diuretic, whatever, a diuretic goes, sodium goes. Whatever water goes, sodium goes, and potassium most of the time. So you're going to check for potassium because of action potential and the fact that too little potassium could lead to arrhythmias, right? If you're giving anticoagulants and you're going to check for heparin, for instance, or warfarin, you're going to check for PTT or INR. If you're giving metoprolol, you're going to check for heart rate and BP. If you're giving nitroglycerin, you're going to check for BP. Why? Because you already know your meds. And you know what could happen if you give that med without doing your due diligence. You know that if your patient has a very low potassium and you give a diuretic without actually replenishing that potassium, and diuretic is anything but a sparing potassium diuretic, then the potassium is going to decrease exponentially, and then you might have an issue in your hands if you do that. So you follow protocols, but you always want to be safe. You always want to make sure that you know the medication you're giving, but not only that, that you know that your patient is ready to take this medication. Is that understood?
Excuse me, Professor, I have a question.
Go ahead.
For example,
Sure.
if I have to give a diuretic like furosemide, okay?
Yeah.
I give furosemide. I'm not supposed to give potassium after that? No.
You're supposed to check the potassium before.
Before, okay.
So let's say you have an order for furosemide, LASIK. So I'm assuming your patient is maybe congestive heart failure, right?
Yes.
So he's congestive heart failure. He's got extra fluid in his body or her body, and you're trying to work with preload and afterload, and you're trying to do your best, right?
Yes.
And furosemide has been ordered. Now you know that this type of medication, it's a diuretic that will increase the loss. I mean, you will lose sodium and potassium, right? And then you know that sodium and potassium are a part of action potential in the cells, right? And you know that too much sodium and too much potassium can lead to arrhythmias. Too little sodium and too little potassium can lead to arrhythmias. So the last thing you want is a patient going into an arrhythmia if you are the nurse of that patient. Because then you're going to have a code in your hands, and then you're going to have to do all the CPR and all that, right? So before you give the medication, you should have known already, all right, let me check today's labs. So you go into the system and you look for chemistry. And then in chemistry, you're going to get either a BMP or a CMP. And right there, you're going to check sodium and potassium, which are the first two. And if the potassium is too low, let's say you open that and the potassium, your potassium is 2.0. Would it be a good idea to give this medication to the patient?
No.
Why? Because he's going to lose some more potassium. And then he might go to a place where you don't want him to go. So what do you do in that case?
Hold the dose.
Hold the medication and you call the doctor.
That's right. You hold the medication and you call the doctor. Now, you still might need to give this patient some diuretics. And we have diuretics that are sparing potassium diuretics, such as spironolactone, for instance. And the doctor might say, if he deems this appropriate, well, let's change the medication. Let's get this patient spironolactone, or he could tell you, let's add an order of potassium IV or potassium PO if he thinks that the patient can drink potassium, right? To get that, or let's change the diet reach that in potassium, or there are many things that he might want to do depending on the acuity of the patient, where the patient is at, and the type of situation that the patient is experiencing. But by by doing your vital signs and doing your due diligence, you just save this patient's life. Just by knowing, just by looking, okay, potassium 2.0. Oh, that's great. That is awesome. That is fantastic. Let me call the doctor and let me let him know that this is not the best for this. It's work between you and the nurse practitioner and the doctor who's taking care of the patient. You're both, if you do it like this, you're both doing a fantastic job. It means you know your job and he knows his job, and you're both doing great, and the patient is the one who actually gonna reap the benefits of you being a good nurse and him being a good clinician, a good nurse practitioner, or a good doctor. Same with nitroglycerin. For instance, nitroglycerin. What happens with nitroglycerin? What happens when you take nitroglycerin? What happens to your body? It's a nitrate.
It lowers the blood pressure.
It's gonna decrease the blood pressure. Why? Because it vasodilates. It's a vasodilator. So your veins and your arteries are gonna get bigger. And then if your veins and your arteries, they dilate, what happened to the blood pressure? It decreases, because your blood pressure by definition is cardiac output, the output of your heart, versus vascular resistance, which is your heart and your veins and your arteries, the resistance of the veins and the arteries. That's what we call blood pressure. So if your heart it's pumping, but your arteries are expanded, by definition, your blood pressure is going to decrease. Now, if at the time of you giving nitroglycerin, either changing a patch or giving it sublingual, or in the case of an emergency, doing a drip, a nitroglycerin drip, if at that time your patient is having a blood pressure for any reason, sepsis, or whatever it is, of let's say 80/40, maybe the use of nitroglycerin should be avoided, because you will create more hypotension. And then if you check a blood pressure before you give it, then you're doing your job. You're doing your job because you know, okay, the blood pressure is too low. Maybe nitroglycerin shouldn't be, but I'm not sure why is he ordering nitroglycerin. Let me give him a call. Let me put a call to this physician so he knows what's going on. And if the order that he's giving you is not correct, and you know that it's out of standards for practice, then you should tell him, listen, I don't think we should do this. You push back a little, and they'll respect you for it. If you know what you're talking about, if you know what you're saying. So warfarin, for instance, it's the INR, which is an international measurement. So if you know that you need to have 2-3 times the amount of INR to medication be therapeutic, but it's when you look at the INR, it's 6 times what it should be, then it's over therapeutic to a point that your patient could bleed. So that's called over anticoagulation, and you need to call the physician and you need to tell him, listen, this is way over. We're giving him too much warfarin. Maybe we should see if the dosage, the dose that we're using, it's being over therapeutic. We shouldn't be using this much. Let's titrate this. It's their decision, but it's in conjunction with you as a nurse. Any questions with this before administration? Guys? Huh? Any questions?
Any question?
No.
No?
Yeah.
Awesome. Awesome. Do not recap needles. Please, guys, don't do that. Even if you see all nurses and surgeons do it, you don't have to. You know what happens when you are trying to recap a needle? You get stuck. Yeah. You get stuck. Most of the new needles, they have this safety fixture where you can go like this, boop, and then the needle, it's either pull back or totally covered. But and then if you have that system, that's great. Once you do that, you can move the needle. But some of them don't. And depending on the hospital and whether they want to spend a lot of money on safety features or not, or the company you're working for, you might be working with needles that are they have safety features, and some of them don't have safety features. I'm sorry. So if they don't, do not recap. Don't recap needles. When you're done, make sure you put your needle in one of those needle things, the container, the red containers, where you can just either stick the needle to the foam, or you put it back into a container that it's approved by the agency to storage needles and to storage these type of instruments, syringes, needles, scissors, scalpels, and so forth. Do not throw needles into the regular garbage or garbage for blood, but it's not approved. It's not a container for needles. You don't want to do that. Somebody's going to come afterwards, guys. Somebody who is not a clinician, somebody who is going to be working with the trash, and they don't know a lot about it. You know, even if they're trained, they're not nurses. And if you throw a needle there, they might think you know what you're doing, but you threw a needle in that place, and then they can get stuck. And you have the chance to actually look at the patient charts and talk to the patient right away if you get a prick by a needle, but they don't know where it's coming from. Imagine the anxiety of a person who doesn't know what happened with that needle. So dispose of any unused medication according to policy and agency policy, not in a trash container, please. Needles to a needle container. Recapping, no, that's a no-no. And then after administration, of course, you're going to monitor the patient for side effects. All of your medications have side effects. They are not perfect. You need to know your meds, and you need to know what they do. The more you know as a nurse about your meds, the easier your job is going to be, because you're going to be able to anticipate what could happen before it happens. You know what to expect. So you're going to work, let's say, it more relaxed, because you'll be able to identify side effects from this and that medication. When it comes to NCLEX, they can ask you if you know the side effects of the medication of the group or of in a specific group of medications, then you will be able to answer your questions correctly. And evaluate the client for therapeutic response to the medication as part of the nursing process. Questions about this? So let's do oral. You're going to administer oral medications. How do you give it to a patient? What do you do? Let's guide me through an administration. Tell me what you do. Oh, I'm sorry. I fell asleep. Can you turn on your cameras? I know it's been 2 hours, 2.5 hours, guys. Not much longer. Turn on your cameras, please. It won't be much longer. I know you're getting tired already. It's been 2.5 hours. I understand. I understand. And it's easier for me because I see this every day and you guys are looking at me already like, we don't want to make you feel bad. We know you're a nice guy, but we're tired already. I get it. I get it. Let's just finish this part and then we can meet next week. All right. So oral medications. Should you just open the thing and give it to the patient using your hands?
No.
No, you wash your hands, you put on your gloves, you get a tap, you get a container and you drop it inside a container, guys, please. Come on. Don't be getting the mail like that. Open your mouth with your hands, with the same gloves that you were using to tuck the rails. Drink this. Use a nice clean container. Wash your hands first. Medications into the container, and then you go and you talk to the patient, look, drink your meds, right? If you're giving those medications that are PO through an NG tube or a PEG tube, you should know that enteric-coated tablets, sustained release tablets, they are not to be crushed. They are not to be crushed. That's a no-no. There's a reason why they are like that. Use a medicine cup if you're going to pour medication, like liquid medication, and put it like this. So you can see, not like this, so it looks like it's too big. No, like this. So you can see exactly what you're pouring. If you're looking at it like this, 5, what you're seeing as 5 might be 7, and you don't want to get 7 because that's double dosing, right? Or more than what you should be given. Volume of less than 5 milliliters are measured with the use of a calibrated or a syringe. Do not mix medication with food or milk, especially in children. And if the patient vomits, do not repeat the dose. Call the doctor. Let him earn his money. Give him a call. All right? Sublingual. What is sublingual?
Under the tongue. Under the tongue.
My students, what do you put a tablet that is sublingual? Under the tongue, right? Always. And buccal?
Between the cheeks.
Between the cheeks. Shall you drink water while you're doing a sublingual tablet? No, you wait. You wait. Can you swallow a sublingual tablet? No. You should not eat, drink while the tablets are in place. Odette, good seeing your face. Look at that. Oh my God. Unbelievable. You're almost done.
Yes.
It's unbelievable. Time flies, people. Time flies. Time flies. So follow directions for dilutions and shaking and so forth. That's the way you're supposed to do it, you see? That's the way. You're doing NG tube, and you will be doing NG tube medication, and you will be doing gastrostomy tube, whether it's a percutaneous gastrostomy tube or whether it's a GI data, you'll be using that tube in the stomach to give medication. You check for residuals. You make sure the tube is in placement. How do you use something fantastically new? You know how it's called? An stethoscope. You know, it's that thing that you put in the ear and you press to the body and then you hear sounds that it's only been around like for 100 years. You use that. Put it into the stomach and you go like, and then you listen. Oh yes, my NG tube is in the stomach. My PEG tube is properly placed. Before you give the meds, you make sure that you know with that fantastically new thing called stethoscope. You know, the one that you put in your ears. The one that every nurse you have around his neck. The one that people think that it's only for doctors. You know, oh, if he has a stethoscope, he's a doctor. No, if he has a stethoscope, he's a nurse. Because the amount of things that you do with your stethoscope every day, it's unbelievable. You listen to lung sounds, you listen to the gastric sounds, you listen to heart sounds. You do that every day as a nurse. So you should have one, and you should have a good one. Please, don't buy a $3 one at Walmart.
Excuse me, Professor, can we save the one that we got from school?
Can you hear with it?
Yes.
Can you identify the sounds with it?
Yes.
Do you like it?
Yes.
Is it fashionable? You're a girl.
No.
Well, up to you. Then it's up to you.
Okay.
You know, my stethoscope has been the same for 15 years. It wasn't that expensive. It's expensive. It cost me maybe, I don't know, $100, $150. I bought it in 2013. No, 2011, when I was doing my nurse practitioner. I bought it, and it's been with me for years and years and years, and it lives with me. It's in the car, or it's in the wall, or it's because you never know when you're gonna need it. And if you're a near nurse, you're gonna need it all the time. And if you're given medications through a nasogastric or gastrostomy tube, you definitely need it because you need to check for residual, and you need to check for tube placement, and you need to check for sounds. Then you use a syringe and allow the medication to flow by gravity in the plunger like this. You shouldn't crush, stand it, or time release tablets. Please, enteral feedings are just that, enteral feedings. Do not mix medication with enteral feedings. You shouldn't mix medications with feeding most of the time. That's one of the first rules that we just saw. Food and medications, they don't always match. Do not mix medication with enteral feeding. I see this all the time. The patient is being fed. Oh, let me give it the tablet. It's going to be good for him. No, 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 no. You stop the feeding. You make sure you check for residuals. You flush for lukewarm water, 30 seconds, and then when everything is flushed and ready, if you can do it, and if it's the right time to do it, you put your meds in. Do not mix it with feeding. Don't do that. Flush the tube before and after medication with 5 to 30 milliliters of warm water. You got that?
Yeah.
Lithotomy position, rectal suppository. If you're a boy, you're gonna do this to a woman, please bring a witness. That's my advice. You have to put the patient in Sims position. Look at the legs. And then you have to insert your finger in his rectum, and you have to check that it's no stool there. You don't want to put a suppository inside a bunch of stool, so he goes out and he poops, and the suppository goes with the poop. You don't want to do that. You want to make sure there's no poo-poo. So you lubricate the suppository and you insert at least 1 inch beyond the internal sphincter. And then you tell the patient to remain on bed for 15 minutes. That's the right way to put a rectal suppository. It's not like, excuse me, sit down and see you, arrivederci, I'm in a hurry. No, that's not the way. You don't do that. So, vaginal suppository. NCLEX is not gonna tell you this. Everybody's gonna tell you your nurse as much as please guys. If it is a young lady and you're a male and you have to do a vaginal suppository, get a lady with you. You're gonna have to put this lady in a lithotomy position. And then you're gonna have to lubricate the suppository and insert 2 to 3 inches towards the sacrum in this lady, and then instruct the lady to remain in supine position for 15 minutes, like that, like this. That's the right way. Parts of the syringe, needle cap, the bevel, the shaft, and the hub. For those of you who weren't paying attention, I'm pretty sure you all were paying attention because you all were here. You do not recap this into this. Once this is out, it's out. You don't put it back. Tip, barrel, and plunger. Like a gun. Ampules and vials. Right? So, if you're using a vial, the risk of actually getting any kind of a residual glass, it's very low to none. But if you're using this right here, you're going to need a blunt filter needle. You know what that is? It's a needle that filters any kind of residual glass, kind of like form that could come from you breaking that ampule. So you use your filter needle, you get your medication out, you take off the filter needle, you get rid of the filter needle, you find the needle that you're going to use, and then with that one, you either inject the medication into a patient if it's intramuscular. If it's just an IV medication, you get rid of the needle, you get your syringe, and you go and you inject your medication into the system. Questions? No?
Excuse me, Professor.
Yeah.
For the ampoule, we have to cut it.
For the what?
The ampoule before using it. That one.
Oh, yeah, you have to cut it. But most of this you don't have to. You just press on top of the ampule, and it will break.
Okay. And
some of them have a system that if you do like this, the medication won't even go out of the ampule.
Yeah.
But there's always a chance that some residual kind of glass could be inside or around the ampule. That's why you use the blunt filter needle, which is like a regular needle with a filter that is kind of white.
Okay.
That's the one that you use, at least the ones that I have seen so far.
But last week I have been to lab. We were doing that. The teacher used a special, the one who is covered with a pink cap, pink something like that. She said after remove the medication, you don't have to use that needle. You have to use another needle. It's just only to get the medication out.
That's right. That's what I told you. If you're gonna use another needle for an intramuscular injection, you can't use the same needle. You should never use the same needle. Many reasons why. The first one, all of these needles are very sharp, but they get blunt real easy. And then can you imagine you are getting medication from a vial and suddenly you go in with the needle, you get the meds out, and when you get it out, that needle, first of all, it should be a very thick one. So you don't want to inject a medication with an 18 or a 16 needle. I mean, the patient is going to be very afraid of you if you go to him with that needle. And second of all, that needle is already blunt, and you're going into a muscle, and you're going through a skin. You shouldn't use the same kind of needle. It hurts. It hurts. It really does. So take that needle out and use a new one, the appropriate one for the type of medication you are putting in the body.
Thank you.
Because it's not the same for intramuscular as it is for intradermal, right?
Yes, thank you.
Listen, Marie, sometimes I over-explain. Let me know if I'm being too simplistic, okay? I like to do it because
okay.
I like you to understand.
Yeah.
And sometimes people just take for granted that you guys know things, and sometimes you don't.
No problem. When I miss something, I let you know. Thank you.
Please do so. And if I say something that you don't agree on, just tell it to me too. Not perfect, far from perfect here. Okay?
Thank you.
All right, guys. Oh God, what happened here? Oh,
We are here.
right. So if you're gonna do parental administration, the vastus lateralis for infant and children are the area that we should use. You should not inject more than 1 milliliter of fluid, guys. Have you ever had an intramuscular injection given to you?
Yes.
It hurts. It hurts. That's why we have protocols. Can you imagine to a kid in the vastus lateralis? It's gonna hurt. And after 2, the ventrogluteal side should be used up to 2 milliliters. I have seen people do some things, like having a full 6, 7 milliliters or 3 or 4 milliliters syringe and going and putting in an intramuscular injection. If it's that big, guys, it should be divided. I mean, you might think, well, but I gotta stick in twice. Yeah, you do. You have to stick in twice. That's the way it's supposed to be. That's the NCLEX asks you something about this. That's the way you're supposed to answer. You're supposed to answer yes. You have to divide it and do it twice. The deltoid side can only accommodate up to 1 milliliter of fluid, and a tuberculin syringe for solution is less than 1 milliliter, of course. And please discard off sharps and this in the designated containers. Intradermal. This route is usually used for tuberculin testing, checking, or for allergy sensitivities when you go to a doctor to check for your allergies, and it's small amounts, and I mean 50%, 50 angles, 50-degree angles. Subcutaneous, it's going a little further, okay? Hold on a second, guys. I lost you again. I'm dying here with this. I don't know what's going on today. Okay. Commonly used. Yeah. Can you see me now? Can you see everything?
Yes.
Okay. Commonly used for insulin and heparin subcutaneous. You're going to use a 3/8 to a 5/8 inch 25 to 27 gauge needle. We'll see the needles later, by the way. We're going to see them later. For an average size client, it's 45 to 90 degrees. You select the size, especially if it's subcutaneous, you know you're looking for fat, right? You're looking for fat. The abdomen, the upper hips, lateral upper arms, the thighs. You have to rotate the ejection size, especially some medications such as Lovenox. you shouldn't inject on the same site every single time, right? And aspiration of blood is not required for this medication.
Professor, I have
Yeah.
a question.
Go ahead.
For what needle size you are going to use for a patient, a 19-year-old patient that weighs 80 kilograms
Right.
in ventrogluteal size.
What is the question?
The needle size.
That will be an intramuscular one, right? So,
Yes.
so you're gonna use ventrogluteal, deltoid vastus lateralis if it's a pediatric, right? If it's a pediatric patient, you're gonna use vastus lateralis. If it is a normal person, you're gonna use ventrogluteal, right?
Okay.
Right. So depending on which side you're going, it could go from 20 to 25. Right. Those are the size of the needles. And it could go from, it should be 1 to 1.5 inches long. So you're using from 20 to 25, 1.5 inches long, depending whether you're using ventrogluteal or you're using vastus lateralis as your site for the injection.
Yeah, it was a question I saw, and it says ventrogluteal site in a 19-year-old patient that weighs 80 kilograms.
That's a regular
the
patient.
options
That's about
were-
160 pounds. 160 pounds. 19-year-old. Oh, get a 20, sweetheart. Let him suffer. All the way in. All the way in. 1.5 inches. Ventrogluteal. So 1.5 inches because it depends on the size of the butt, you know? It could be 1 to 1.5 inches, and then you go in and you inject your medication with a 20.
20, okay.
Yeah, that's what was the question? That was the question, something like that?
Yes, it was.
And that was the answer was there. 20.
It was 20, 21, 18, and I don't remember the other option.
It should be 20 to 25. It shouldn't be an 18. That's overkilling. That's not an 18. It's a rail. It should be a 20 to 25, depending on the site you're using, whether it is ventrogluteal or vastus lateralis. Of course, if it's vastus lateralis in a pediatric patient, you don't want to use a 20. You want to use a 25 or something like that, you know, or a less thick and long needle. But it should be at least 1 to 1.5 inches long, the needle.
Okay, thank you, Professor.
Does that answer your question?
Yes.
Professor, I have a question. It was a patient that he was obese, and he will be getting an intramuscular medication. So it was asking about the needle. Should it be bigger, longer needle, or because the patient is obese or overweight, or just stay with the same size?
You're using ventrogluteal, right? So, I mean, it could be very obese, but the technique is there. It's 20 to 25, 1 to 1.5 needle. That should be enough to get into the muscle. You're not going, remember, you're not going from the top of the butt all the way in, like if you were doing you're going on the corner, on the far, you'll be okay. You'll be okay. You're using, the way you're doing it, it's you're using technique to do this. We're gonna get to that in a few minutes so you can see the images, okay? And it shouldn't matter whether the patient is obese or not at the time of doing an intramuscular injection. You should be able to do it with the needles that you have. And you can always change your site and go vasolaterales or go deltoid if you need it, if the guy is too big, you know. Just make sure you're using the right amount of medication solution and the right needle if you're going deltoid or if you're going vasus lateralis. Does that answer your question, or maybe not, or does it?
Yes, thank you.
Okay, okay. Oh, right there, look. You see? You find your iliac crest, your anterior superior iliac spine, and then you put your two hands like that, and you see this is the butt. You're not coming from here all the way down. You're kind of going on the side that is always going to be less thick. You're not gonna go all the way here. Boom, boom. No, you're coming from here. Look, if you were to measure from here to here, it wouldn't be the same measurement as from the side, right? You understand? You could use airlock technique or you could use C-track technique. That's deltoid. And that's vastus lateralis for a kid. That's airlock. So you're going all the way into the muscle. You have your air. First, then your medication, you go all the way into the muscle, you push the medication, and then you push a little bit of air, and it locks the medication right there. Parental medication. This route is appropriate for administration of medication, fluids, and blood products. You need vascular access device to do this, which could be long-term or short-term use. The right vascular access device. Why do we use the right one, guys?
Based on the needs for the patient needs. If you have to give the medication for a long time to this patient, or the diagnosis of the patient, the condition that the patient has.
The medication
Depending on what we're injecting.
The medication that we're
If
using.
it's blood, yeah, you need a bigger needle.
Let's say you're using a catecholamine on a patient. Let's say you're using norepinephrine, which we also call Levophed, right? And there is an extravasation due to Levophed. What happens to that tissue right there due to vasoconstriction? It gets destroyed. And Phenethylamine should be used right away. So that's why you should not give these infusions on vascular access that are not appropriate because of the risk of actually a patient losing limbs. I've had a patient at a given hospital once, not saying names, not saying where, not saying nothing. An example, and it was real, but for the purpose of this review, it was hypothetical, which came down for a procedure with a PICC line, actually. No, with an IV, an 18 gauge IV, which is a big one, and it was ultrasound guided, meaning it was even better because it was deep inside. So you would think that vascular access could withstand live off it for a long time, right? Well, let me tell you one thing. The vascular access got actually it was faulty, and Levofed went all over his arm. It destroyed that. Even with the use of pentolamine afterwards and everything, the alpha blocker, it destroyed the whole thing. And the patient ended up losing his arm. From here. So you have to know your vascular device. And you have to know for how long you can actually use that vascular device, whether it is for 18 hours, 20 hours, whether your patient you should change the vascular device, whether you should put an order to a PICC line nurse and talk to a physician to change it from a peripheral access to a power glide or to an actual PICC line, which is a central line, or to a central line done by a physician, or to a tunnel catheter for long-term medication, and so forth, or to there are many different type of vascular access. And it's your duty to know which one is correct for the type of treatment you're giving to your patient. Now, for the purpose of something short, if you're taking care of trauma patient, it's 16 gauge, big one. 18 gauge for surgical clients, 22 to 24 for children, and some other adults. The preferred sites are peripheral veins in the arm or hand. In neonates, veins of the head, lower legs, and feet might be used, not in adults. Those are epidural administration of intravenous opioid analgesic, morphine or fentanyl. You need infusion pumps. You do not put those catheters. It's not your responsibility to place those catheters right away. Eye drops, ointments, you can study that at home, okay? And I'm gonna stop it here. Let me go here. This shows up a lot. Have you seen these type of questions? Eardrops, yeah. For some reason, ointments not that much, eye drops more or less, but this, it's like everywhere. It's like everywhere. So in adult, put your ear back and up, right? In children, what do?
Back and down.
Down.
That's right, back and down. If it's a patch, don't touch inside of a patch. You don't want to do that, okay? Wear gloves. A nitroglycerin patch, if you touch it inside, you're putting nitroglycerin in your skin. So you shouldn't be touching patches without using gloves, right? If you change it, you clean it. If you're gonna remove it, you clean it, and you put the other one in a different site. You can't put the other one unless you take this off. There's still medication there. You shouldn't put two at the same time. You shouldn't violate the patient this way. Rotate the side of the application and place patches needed to remove before going to MRI, because some of them have metals, and you shouldn't take a patient to MRI with metal in the patches. Check the inhaler well and remove the mouthpiece cover. Shake it, remove it. Breathe out through the mouth before you do it. Place it in your lips, right? And securely around the mouthpiece. Inhale, pushing the top of the medication while inhaler, meaning, right? Hold your breath for a few seconds. And exhale. If you have to do it a second time, you wait a couple of minutes until you do it. You have to know the difference between SABA, SABA, and LLBA, LABA. Short-acting beta adrenergic, long-acting beta adrenergic. Know this. For acute asthmatic attack, you're only going to use short-acting one. There are 3 of them. You use them. Those are the ones that you use. You should be used. Albuterol is the one that we use the most. You don't start with anything else. You start with albuterol. The rest of them are not indicated for the treatment of acute asthma attack. Only short-acting are. Long-acting are for the maintenance, not for the treatment. Short-acting ones. And if you're inhaling steroids as part of the treatments, which are part of the treatment, you should rinse your mouth and make sure you go to the doctor every 6 months, to a dentist, and so forth. This is it, guys. I'm stopping here. It's been only 3.5 hours, right?
Professor, I don't want you to finish.
You don't want me to finish? I feel flattered, guys.
No, it's good
You
information.
can continue.
Listen, I'm more than happy to come every Saturday. I mean, you have a wonderful team in the CSA. You have people who are committed. They're actually dragging me on a Saturday. And you know that Saturdays I like to do things, you know? So they're telling me to come on a Saturday. Follow Dr. Azarero's lead. Follow Yoan. They really want you guys to succeed. They want you guys to succeed in what you're doing. They want you guys to achieve passing that NCLEX the first time. They're dedicating time, guys. These guys you're working with Yoan, with Dr. Azarero, they don't have a time of the day. I wish I could show you the messages. 12 o'clock, 11 p.m. Sometimes I'm thinking, oh my God, they are really, really, really into this. They want you to succeed. They want you to pass the NCLEX the first time. They want the university to keep their accreditation for future generations of nurses to be able to be graduated in an institution with the right accreditations, like you are. So guys, follow the leads. If they tell you go and take the exam, go and take the exam. They are not wasting your time. Was this a waste of time today? Was this a waste of time? No.
No.
No, of course not.
Then you know what? Same thing with what they're telling you. They're telling you because they don't want to waste your time and they want you to be successful. If you haven't taken the CAT, go take it. If you have not taken the CAT exam, go take the CAT exam. If she tells you take it again, take it again. If she tells you this is what you should do, these are smart people. Just look at all the letters after Professor Azarero's name. You have to get a go-kart to actually finish all those letters from top to bottom and drive it through it. They know what they're doing. They've been through what you are doing now. I have been to. So we want you to succeed. Follow our leads. Do what we tell you to do. We're doing it for your own good. Go take the CAT if you have to. Take it again. Take it again. Do not present to this exam unless you're ready. A second time it's murderous. Not only because for some reason the exam can be more difficult, that will be subjective, we don't know. Psychologically, taking that exam a second time is devastating. A failure can be a source of improvement, but it can also be a source of fear. And then if you don't have to fail in this exam, you shouldn't. And you don't have to. You're ready for this. You just need a little bit of guidance. So let yourself be guided and take the CAT exam, do whatever needs to be done. And I promise you, you'll pass your NCLEX, and then you'll go on to better things, helping people. And hopefully you keep on studying, become nurse practitioners, and one day come back and teach. Right? So guys, see you next week, okay? My pleasure. 11 o'clock next Saturday.
Thank you.
Thank you,
Okay, thank you,
Professor.
Professor.
Thank you. Bye.
Bye,
Thank
guys.
you, Professor.
Bye.
Bye.
Thank
It's
you.
been great seeing your faces.
Thank you, Professor.
Take care, guys.
Thank you.
Yoan.